Thank you, Annika, for this invitation. So I have no financial disclosures for any of the products mentioned or implied in this presentation. Now, all of us have, at some stage or the other, come across these dense, hard brown cataracts in our OPD. And the first reaction which happened to me when I was a resident was a thing of shock, because we all know that this one is a tough nut to crack. And what are the concerns out here? The main problem that we are concerned about is of the potential damage that we can occur to the posterior capsule. We can dislocate some of the zonules. We can cause damage to the cornea. And of course, most of these hard brown cataracts are associated with some comorbidities or the others, like weak zonules. Some have got thin posterior capsule with strong corticocapsular adhesions. There is a compromised endothelium in many of these old patients who have waited for a very long time. Pseudoexfoliation is another thing that's very common with these hard cataracts. And of course, they have a lot of systemic comorbidities. Many of these patients are hypertensives, diabetics, on blood thinners for a long time. The concern about an open globe as well as an expulsive hemorrhage, all these things, thoughts come to mind. And of course, the basic principle in any cataract surgery when we are doing phaco, the main thing is that you need a nuclear disassembly. And that can be done by any of the methods. But for those who are venturing into hard cataracts the first time, probably the stop and chop is the most efficient and the safest method as far as this thing is concerned. As we mentioned in our previous talk, femtosecond laser again comes to our rescue in most of these difficult situations in cataract surgery. What it does in case of hard cataracts is, of course, ensures there's a perfect central capsulorhexis. It creates planes of cleavage so that there is easy to disassemble the nucleus. It also leads to minimal stress on the zonules because you aren't using too much energy out here. And of course, it also softens the cataract by using the fragmentation mode. Now, this is the first case. This is a straight grade 4 cataract that we are doing. And the first thing that is very important in all these cases is that you must make a long, deep, and a wide trench. Remember, one should not be afraid of trenching deep in these cases because most of the time the cataract is very hard. You like to make a wide trench so that as you're going in, the tip along with the sleeve can get to the bottom. Splitting once you are able to go down right to the posterior edge is quite simple. This is a case of a femto. So as you can see that those planes of cleavage have already been created. This ensures that perfect separation takes place. You see that most of the work is done by the chopper in the left hand. There's not much that you have to do with the right hand except to hold the nucleus very high. And what one tip I would give you is that make sure that when you're using hard cataracts, you're using high vacuum to hold, because if you use high vacuum and hold these pieces well, chopping becomes very easy. So typically my setting for this during the chop mode, for holding the nucleus, I would use about 600 or even 700 millimeters of mercury. Not so much of vacuum when you are aspirating the piece, but it makes sure that you have good planes of cleavage. So once you have achieved that, and you have managed to separate, and of course make sure that you separate it all the way down to the bottom, right to the tip of the posterior capsule at right in the center. And then, as you can see, there's not much work to do with the chopper in this particular case, which is a grade 4, because you are using torsional along with a longitudinal. A combination of that ensures that the fragment remains at the tip, and so therefore it becomes easy to aspirate the nucleus and make sure that everything goes well. But this is one of the easier cases, I would say, that where the cataract is not very dense. It's maybe early grade 4, but it was hard, as you can see. Of course, the use of the femto made sure that it was very simple and very easy to make. And of course, one thing we have to ensure always is keep the chamber stable, because you're afraid about causing any potential damage to the corneal endothelium. So do not use very high vacuum when you're aspirating those pieces. At that time, the typical vacuum setting would be about 350 millimeters of mercury, and that should be enough. A flow rate of about 30, as well as a bottle height of about whatever you normally use, about 80 to 100. In this particular case, I was using a Centurion, so maybe talk in terms of, now this is the next case. Now this is denser than that. In fact, this is a 72-year-old lady gynecologist, and you can just see that the cataract was quite hard. When the posterior capsule is not visible, it's very easy to make a mistake. If you do a violent hydrodissection, there can be a blowout of the PC. So make sure that you do a gentle multi-quadrant hydrodissection. Again, make sure you go deep down till you see those leathery fibers at the base. When you see those leathery fibers at the base, it's not sometimes a problem to even phaco in that area, so that you have a really deep trench out there. Of course, separating again, when you're separating again, you make sure that you hold with a very high vacuum. This ensures that basically you do not slip. The piece tends to slip if you do not hold it properly. Once you've done that, you have to make sure at the same time that you don't stretch it too much, because you're laying stress on the zonules. And that's where the stop and chop becomes a good method, because you're always leaving some kind of space in the center, and creating that space in the center does not lay too much stress on the zonules. Otherwise, in a very tight bag, a very tight nucleus with hardly any cortex out there, you can sometimes cause damage to the zonular complex. Once we have done that, most of these cases ultimately then become very easy. As you can see, as opposed to the first case, a lot of work is done by the chopper in the left hand now. For one, it helps to get the nuclear material to the phaco tip. And the second thing is that when you're using a combination of a torsional and a longitudinal, it also is useful to help the nucleus remain a little away from the phaco tip, because you need just the tip of the nucleus at the shearing plane. If you stuff too much, it's easy to clog the nucleus, and all the time you have to take the handpiece out to kind of remove the clogged material that gets clogged over there. So you just bring it in and then keep it away. I would compare it like to the seal in the circus who's balancing the ball on the tip, and you think that he's balancing it on the tip of his nose, but all the time he's moving the nose to keep that tip just bobbing up and down, and this will ensure that the nucleus remains over there without flying off to the endothelium, as sometimes it happens, and with potential damage over there. The use of a soft shell is very important in these cases. I always put in chondroitin sulfate, that's viscoat, right in the front against the endothelium, and below that at the base is helon, so that it ensures that there's a good fragment right towards the end. Now, sometimes you get a case where you don't have a well dilated pupil, and as you can see, then in that case femto is not possible. You have to go the conventional method. As you can see in this case, I've used a Malaysian ring. You can also use a BX ring. My choice of the ring depends on how rigid the pupil is. If it's a rigid pupil, I'd prefer a Malaysian. If it's not so rigid, then maybe I would put in a BX, and I think that works pretty well also. Of course, the dilatation you get with the Malaysian is a little better as compared to the BX, but no particular preference out here. Again, as you can see, those leathery fibers, you go deep down to the base, and then of course ensure that the separation takes place. Now, I just heard the bell, so in the interest of time, I will move over this case, which is more or less a repetition of that. But in this case, the only thing that was very stressful was a 90-year-old, one-eyed patient, and he had lost his first eye due to vitreous loss and retinal detachments in the previous eye, hesitated about doing the second eye till his son, who was a radiologist, literally forced his dad to come on the table. So we had a very anxious patient who had been given a little sedation, but we somehow managed to do the case. And as you can see, we had even planned for a toric lens, and I'm happy to say that this person enjoys 6/6 unaided vision today. So I'll just move on to the last case, which I thought I will share with you because it's very important. So sometimes you have another one-eyed patient here who's lost his second eye, and now this is such a dense cataract that I didn't dare to think of doing a phaco. And remember, we should leave our egos aside and not stick to phaco for every patient. So I attempted a small incision cataract surgery with a good outcome. As you can see out here, after we have done a large rexus, the classical wave that we like to see, we ensure, first of all, the lens moves, and then, of course, put in that fluid wave so that the pole pops up from the other side. As you can see, the wave of hydrodissection moves against the posterior capsule, and we're just waiting, yes, and then it pops out. And once it pops out, it's not that difficult. You rotate it around and spin the lens out of the capsular bag. Once the lens has come out in the capsular bag, I injected visco underneath the lens. That ensured that I was going to do a visco expression, use a vectis to engage the nucleus in the wound, but the nucleus was very large. It wasn't coming out, and of course then at that time, I remember those gynecologists who used to have those difficult deliveries, and they used to thump on the fundus of the uterus from the back. So here you can see I can go from the side port and push that nucleus into the wound, And once it is into the with using the same 26 gauge needle that was used for the capsular rhexis, got that entire nucleus out. And of course, I didn't lose my chance to give him a refractive result. As you saw, despite everything, I decided I'm going to use a toric lens. I had calculated my SI to be about 1.5 for a large incision like that, and I put in a toric lens, and I managed to get a good refractive result in this patient. So that's all that I'd like to basically tell you. Most of these things require a lot of patience. You should take a lot of time over these hard cataracts. Don't keep them in a very, when you're very tight for time. You should do these cases slowly, gently, and I think we can all have a very good result as far as this. This was literally the end of this procedure, and the case was closed with a coaptation with the help of cautery. Thank you so much, very much for your attention. These are a few points which I went through during the course of the talk. Yeah, thank you so much.
Thank you very much, Dr. Sandeep Nagvekar. Actually, one more thing I wanted to ask you regarding the rhexis. Any specific preference for a slightly larger rhexis in these cases?
I always attempt a larger rhexis. About between 5 to 5.5 millimeters is my choice of rhexis. I won't go larger than that.
Not larger than that,
yeah, but about 5.5. Yeah.
Compared to a routine case or
yes,
compared to
course,
a posterior polar where we mentioned around 5.
But many of these hard cataracts have small pupils also, so sometimes you need to put a ring.
We can't really.
But yeah, you must have a large rhexis. It makes job much easier. Yeah, definitely.
That was an excellent talk and lovely videos.